In evidence-based medicine, likelihood ratios are used for assessing the value of performing a diagnostic test. They use the sensitivity and specificity of the test to determine whether a test result usefully changes the probability that a condition exists. Calculation. Two versions of the likelihood ratio exist, one for positive and one for negative test results. Respectively, they are known as the positive likelihood ratio and negative likelihood ratio. The positive likelihood ratio is calculated as, which is equivalent to, or the probability of a person who has the disease testing positive divided by the probability of a person who does not have the disease testing positive. Here T plus, or TAR denote that the result of the test is positive or negative, respectively. Likewise, D plus, or DAR denote that the disease is present or absent, respectively. So true positives are those that test positive and have the disease, and false positives are those that test positive but do not have the disease. The negative likelihood ratio is calculated as, which is equivalent to, or the probability of a person who has the disease testing negative divided by the probability of a person who does not have the disease testing negative. The pretest odds of a particular diagnosis, multiplied by the likelihood ratio, determines the post-test odds. This calculation is based on Bayes' theorem. Application to medicine. A likelihood ratio of greater than 1 indicates the test result is associated with the disease. A likelihood ratio less than 1 indicates that the result is associated with absence of the disease. Tests where the likelihood ratios lie close to 1 have little practical significance as the post-test probability is little different from the pre-test probability. In summary, the pre-test probability refers to the chance that an individual has a disorder or condition prior to the use of a diagnostic test. It allows the clinician to better interpret the results of the diagnostic test and helps to predict the likelihood of a true positive result. Research suggests that physicians rarely make these calculations in practice, however, and when they do, they often make errors. A randomized controlled trial compared how well physicians interpreted diagnostic tests that were presented as either sensitivity and specificity, a likelihood ratio, or an inexact graphic of the likelihood ratio, found no difference between the three modes in interpretation of test results. Example: a medical example is the likelihood that a given test result would be expected in a patient with a certain disorder compared to the likelihood that same result would occur in a patient without the target disorder. Some sources distinguish between LR plus and LRA. A worked example is shown below. A worked example: a diagnostic test with sensitivity 67% and specificity 91% is applied to 20-30 people to look for a disorder with a population prevalence of 1.48%. Related calculations: false positive rate equals type I error equals 1, a specificity equals FP /180 =9%. False negative rate equals type 2 error equals 1, a sensitivity equals FN /10 =33%, power equals sensitivity equals 1 AI squared, likelihood ratio positive equals sensitivity equals 66.67% =7.4, likelihood ratio negative equals specificity equals 91% equals 0.37. Hence, with large numbers of false positives and few false negatives, a positive screen test is in itself poor at confirming the disorder and further investigations must be undertaken. It did, however, correctly identify 66.7% of all cases. However, as a screening test, a negative result is very good at reassuring that a patient does not have the disorder, and at this initial screen correctly identifies 91% of those who do not have cancer. Confidence intervals for all the predictive parameters involved can be calculated, giving the range of values within which the true value lies at a given confidence level. Estimation of pre- and post-test probability. The likelihood ratio of a test provides a way to estimate the pre- and post-test probabilities of having a condition. With pre-test probability and likelihood ratio given, then, the post-test probabilities can be calculated by the following three steps: pretest odds equals, post-test odds equals pretest odds likelihood ratio. In equation above, Positive post-test probability is calculated using the likelihood ratio positive, and the negative post-test probability is calculated using the likelihood ratio negative. Post-test probability equals post-test odds / alternatively, post-test probability can be calculated directly from the pre-test probability and the likelihood ratio using the equation, P equals POL / 1 PO plus POLR, where PO is the pre-test probability, P is the post-test probability, and LR is the likelihood ratio. This formula can be calculated algebraically by combining the steps in the preceding description. In fact, post-test probability, as estimated from the likelihood ratio and pre-test probability, is generally more accurate than if estimated from the positive predictive value of the test, if the tested individual has a different pre-test probability than what is the prevalence of that condition in the population. Example, taking the medical example from above, the positive pre-test probability is calculated as pre-test probability equals /2030 equals 0.0148, pre-test odds equals 0.0148 equals 0.015, post-test odds equals 0.015 times 7.4 equals 0.111, post-test probability equals 0.111 equals 0.1 or 10%, as demonstrated. The positive post-test probability is numerically equal to the positive predictive value. The negative post-test probability is numerically equal to. References: A. B. Gardner, M. Altman, Douglas G. Statistics with Confidence, Confidence Intervals and Statistical Guidelines. London, BMJ Books. ISBN A0-7279-1375-1. Harrell F. Calif R., Pryor D., Lee K., Rosati R. Evaluating the Yield of Medical Tests. JAMA 247, 2543 doi, 10.1001/JAMA. 247.18.2543. PMIDA 7069920 Reed M.C., Lane Dar, Feinstein A.R. Academic Calculations versus Clinical Judgments, Practicing Physicians Unregistered Trademark Use of Quantitative Measures of Test Accuracy. AMJ Med 104, 374 €80 doi, 10.1016 per second 0002-9343, 98, 00054-0. PMIDA 9576412 Sturra J., Fisher J. E., Bachman L. M., Koller M., DeWright G. Communicating Accuracy of Tests to General Practitioners, a Controlled Study. BMJ 324, 824 €6 doi, 10.1136/BMJ. 324.7341.824. PMCA 100,792. PMIDA 11,934,776. Puhan M.A., Sturra J., Bachman L.M., DeWright G. A randomized trial of ways to describe test accuracy, the effect on physicians' post-test probability estimates. Ann. In turn. Med 143, 184 €9 doi, 10.7326/0003-4819-143-3-200,508,020-00004. PMIDA 16,061,916. Likelihood ratios. Retrieved April 4, 2009. Online calculator of confidence intervals for predictive parameters, likelihood ratios, from CEBM. Page last edited, February 1, 2009.